Okay, anti-cancer drugs for the non-specialist. Here we go. There are quite a few cancer medications which are specialized. I don't expect anyone to know all those things, so we're just going to focus on the things that we would probably see in primary care, more so on the pain management side of things, because that's a bit more frequent. So kind of consider this more introductory to kind of chemotherapy. So most common cancers: solid tumors of the breast, lung, prostate, colon, and rectum. These have low growth fraction and respond poorly to drugs. Explain what that means in a bit. The rarer cancers like lymphocytic leukemia, Hodgkin's disease, certain testicular cancers have a high growth fraction and respond well to drugs. So cancer is unregulated cellular proliferation, obviously. And our treatments are pretty terrible. We can do surgery for solid cancers by excising the tumor. We can do radiation, and then we can do chemotherapy or drug therapy, which is a treatment of choice for any disseminated cancers. There's several classes: cytotoxic agents, hormone antagonists, biologic response modifiers, and then there's also targeted drugs. Because of the unregulated proliferation of cells, there is a abnormal behavior of cancer cells to continue to replicate. Malignant transformation results from a combination of activating oncogenes, which are cancer-causing genes, and the inactivation of tumor suppressor genes. One of those genes, for example, is called P53. P53 is supposed to notice when there's too many cells, and then it's supposed to inhibit cellular replication. But in cancer, this gene is knocked out for whatever reason, and so cells continue to replicate even when they're supposed to stop. And this transformation occurs in three major stages. There's initiation, promotion, and progression. The cellular cell cycle has four major phases. In a growth fraction, there's impact of tissue growth fraction on responsiveness to chemotherapy. And chemotherapeutic drugs are much more toxic to tissues with a high growth fraction than to tissues with a low growth fraction. And so here's some of the examples of high growth fraction cancers that originate from the bone marrow, from the skin, hair follicles, sperm, gastrointestinal tract. These are all areas of the body that have high proliferation. So chemotherapeutic drugs inhibit cellular growth, and obviously these areas have high growth, and so it's easy to target them, and that is why those types of cancers are more susceptible to chemotherapy. Unfortunately, it's hard to target cancer cells aside from normal cells because they're all just cells. And in cancer, obviously, you have to kill every single one of those cells. Otherwise, they can continue to replicate after the fact. Here's some other obstacles: absence of true early detection. Solid tumors respond poorly. There can be drug resistance. The tumor cells are heterogenic, and then there's limited drug access to tumor cells. Pretty similar to antibiotics, where the blood flow has to get to the site of action, right? So the medication has to travel to where the cancerous cells are in this example. And if it doesn't, then there will be no action. Um, some strategies for achieving maximum benefit. There's intermittent chemotherapy where we subject patients to cycles. So they'll come in, they'll do a round of chemotherapy. We'll give them time to rest, and then we'll do it again. There's also combination chemotherapy, which is quite useful as we try to target multiple sites of action. And also, this kind of minimizes side effects as we use multiple medications and not crank up the dose on just one particular chemotherapeutic drug. Obviously, we would select effective medications and then go over dosing schedules, which all differ. Here's some other methods of drug delivery. So rather than just doing um, intravenous, there's also intraarterial, intrathecal, and other specialized routes. What are some of the major toxicities of chemotherapy? Well, there's also myelosuppression, which is bone marrow suppression. And obviously, cellular lines originate from the bone marrow. So anytime we suppress that, we're suppressing the number of circulating neutrophils, platelets, and erythrocytes. And obviously, neutrophils lead to our immune system. So then that makes patients with chemotherapy susceptible to infection. A reduction in platelets obviously can cause bleeding. And then the reduction of erythrocytes can lead to anemia. So neutropenia does a reduction in circulating neutrophils. The incidence and severity of infection can be increased. There is a nadir, and the nadir is just basically the lowest point that this can occur. So the nadir in neutropenia for chemotherapy tends to occur in 2 weeks. And for those patients who are suffering from neutropenia, we would give them a GCSF, which is a granulocyte colony stimulating factor, such as filgrastim. And this stimulates the body to produce neutrophils. In thrombocytopenia, there's a reduction in platelets. Similar to neutropenia, we can give oprelvacin, which is Numega, and that would stimulate the bone marrow to produce platelets. And then in anemia, we can also give Epotin or darbepoetin, and that helps to stimulate red blood cells. The guidelines have changed on anemia. When Epotin and darbepoetin first came out, they were promoted heavily. Many oncologists prescribed it, but it then led to a lot of complications, including clots, high blood pressure, strokes, and so the guidelines have changed, and so these are kind of rarely prescribed anymore. Remember those areas that have high proliferation? That would include like the digestive tract. There is stomatitis, which is inflammation of the oral mucosa. And a lot of times patients will get what we call magic mouthwash, which is just a combination of ingredients, typically an anesthetic and an antihistamine with some milk of magnesia. And that helps to kind of soothe the oral mucosa. But because the digestive tract cells are being attacked, it can also lead to a lot of diarrhea. And in this instance, we would give loperamide or Imodium to help prevent that. There is a ton of nausea and vomiting with chemotherapy. Typically, patients will be pre-medicated anytime they are faced with a emetogenic regimen. And combinations are more effective than just a single agent. And typically, you'd see these three being prescribed. So there's aprepitant, dexamethasone, which is a corticosteroid, and then a serotonin antagonist, such as ondansetron, granisetron, and those other types of agents. Other side effects from cancer: alopecia, hair loss, obviously, You see that a lot because hair cells are of high growth. Um, there can be hyperuricemia as cells die. They release their contents, and that can lead to an increase in uric acid levels, which can be fatal. And so, in that instance, we would give allopurinol as a high dose to prevent this. It's called tumor lysis syndrome. It can also be contraindicated in pregnancy as we destroy cancer cells, obviously. A lot of these agents are vesicants, and so they can cause extravasation. So we need to be particularly careful about that. And then a lot of them have unique toxicities. So, for instance, daunorubicin and doxorubicin can cause cardiomyopathy. The platinum medications like cisplatin can cause renal toxicity. And then there's vinca alkaloids like vincristine and vinblastine, and that can cause a neuropathy. This here just for you to review. Cytotoxic anti-cancer drugs are the largest class of anti-cancer drugs. They act directly on cancer cells and healthy cells to cause their death, so they're not specific at all. About 50% do target the mitotic phase when the cells are replicating. And then these cells are these medications are subdivided into 8 major groups. So you can see right here, there's alkylating agents, platinum compounds, antimetabolites, hypomethylating agents, anti-tumor antibiotics, mitotic inhibitors, topoisomerase inhibitors, and then the miscellaneous category. So obviously all our cells replicate. There's a sequence of events that a cell goes through from one mitotic division to the next. And we like to use cell cycle phase specific drugs so that they target these cells when they're in that particular phase. But obviously the medication must be in the blood continuously. So a lot of times these folks will be in hour-long infusion to ensure that happens. And then there's other drugs that are not cell cycle phase specific, which is then kind of useful. So many of our anti-cancer drugs are toxic to normal tissues because, like I said, it's pretty hard to differentiate normal tissue or normal cells from cancerous cells, especially in those high growth areas, right? So bone marrow, hair follicles, the GI, and the skin. Here, this slide just focused kind of on the drugs that can be vesicants and cause extravasation of cells. So you can see there carmustine, dacarbazine, and so on and so forth. Alkylating agents are highly reactive compounds. What they do is they alkalinize the DNA of cells and then causes cell rupture and death. Drug resistance is common, so cancer cells can mutate to be resistant to these agents. But these agents are useful in those high growth types of cancers. Here's some of the older types of agents of these of this class, alkylating agents. So you might have seen cyclophosphamide. And what I've tried to do is just kind of highlight what I think are the most common chemotherapy, at least for me, from what I've seen in practice. These are the ones I've seen the most. That's not to say that someone else could see something entirely different, but you can kind of look at that. So cyclophosphamide, ifosfamide, again, just kind of familiarize yourself with seeing these agents and not necessarily being experts in them. Here's some more alkylating agents. So there's nitrosoureas, and then other alkylating agents such as temozolomide, which is a pill form. Platinum compounds include the platins. These are pretty common. So you can see cisplatin, carboplatin, oxaliplatin. Um, the antimetabolites, methotrexate probably being the most common. And we see that used in numerous types of disease states. There are pyrimidine analogs. You can take a look there. Fluorouracil probably being the most common there. There's purine analogs, mercaptopurine. There's hypomethylating agents, one of the newer classes. What happens is it becomes incorporated into the DNA, and then the DNA unravels, and then the cell dies. And those are those agents there. There are anti-tumor antibiotics, but these are used to treat cancer, not infection. There are two main groups, anthracyclines and non-anthracyclines. Of the anthracyclines, there's the rubicins, so doxorubicin, daunorubicin. These are all those agents that are cardiotoxic and cause cardiomyopathy. And then there's non-anthracyclines, including bleomycin, mitomycin. There are mitotic inhibitors. These are cell phase specific, such as the vincyl alkaloids, which we've mentioned, and then the taxanes, paclitaxel and docetaxel. Here's some other examples. Here are some examples of topoisomerase inhibitors. These are nuclear enzymes that alter the shape of DNA, causing the cell to rupture. Topotecan, irinotecan, and etoposide. Here are some miscellaneous agents. You probably have seen hydroxyurea, typically used these days for sickle cell disease. There are hormonal agents used primarily for breast cancer and prostate cancer, which mimic or block the action of the endogenous hormones. Breast cancer is the second most common cancer affecting women in the United States, and our treatments are typically surgery, radiation, and chemotherapy. Of the hormonal agents, there's two major groups. There's the anti-estrogens, tamoxifen, which we've discussed in prior lectures, and then aromatase inhibitors, which includes anastrozole. There are adjuvant treatments as well, trastuzumab, pertuzumab, lapitinib. They can be used as well. Tamoxifen is used for established breast cancer disease and for reducing recurrence in high-risk patients. It can be used as adjuvant therapy after surgery. So you kind of take out the bulk of the cancer using surgery, and then anything that's left, you could use tamoxifen or chemotherapy to kind of ensure that it's cleaned up. Again, when there's metastatic disease and the cancer has spread, it's not feasible to operate and excise each tumor. So we would have to rely on chemotherapy like tamoxifen to do the job for us. And if you remember, tamoxifen blocks and activates receptors in certain tissues, so it is useful for those estrogen-fueled cancers where tamoxifen can block those receptors. Tamoxifen can cause hot flashes, especially in the first 2 weeks. So just keep that in mind. Nausea and vomiting, because it is estrogenic, can cause menstrual irregularities like birth control, and it is also teratogenic. Some other agents include fulvestrant. This is indicated for metastatic estrogen receptor positive breast cancer in postmenopausal women. Moving on to the aromatase inhibitors, just like in the previous slide, these agents are used to treat estrogen receptor positive breast cancer in postmenopausal women, and they include anastrozole, letrozole, and exemestane. Um, this is a monoclonal antibody to treat breast cancer. And if you've never noticed, anything that's a monoclonal antibody ends in mab for monoclonal antibody. So trastuzumab is one. Um, so these agents can be used before or after breast surgery. You can use doxorubicin to target the breast cancer, plus cyclophosphamide, followed by paclitaxel. But there's numerous types of regimens for breast cancer, and it depends on whether it's estrogen receptor positive or not. As we subject the body to chemotherapy, we're going to cause that myelosuppression. And so we need to determine how to preserve that bone integrity. So typically we'll give bisphosphonates. These two right here are the bisphosphonates that are available as an IV. And that includes alendronate and pamidronate. And then there's a rank L inhibitor, which is kind of the newer agent. It's not a bisphosphonate, but it is used for myelosuppression as well and osteoporosis. And it's a very effective agent. That's denosumab. Prostate cancer is the most common cause of cancer among men in the United States. Standard treatment is we use androgen deprivation therapy, which slows the disease progression, but it does lower testosterone production as it fuels the cancer. So some of the agents we would use are GnRH agonists. They suppress production of androgen by the testes. And these include leuprolide, triptorelin, goserelin, and histrelin. And we would want to use it always use it in combination with an androgen receptor blocker. These agents are generally well tolerated. They can cause hot flashes. And then the testosterone loss may aggravate bone pain and cause urinary obstruction. So again, the GnRH antagonists suppress production of androgen. And as we use those GnRH antagonists, we would also give androgen receptor blockers known as anti-androgens. And those include flutamide, bicalutamide, and nilutamide. This is a newer agent, abiraterone. It's a CYP17 inhibitor. It is combined with prednisone to treat metastatic castration-resistant prostate cancer. And you have to be on a GnRH analog. And adverse events include hypokalemia, joint swelling, and it can be hepatotoxic. Here's some other agents. Don't see these often. Ketoconazole is interesting. It's not used anymore, but you may recognize it as an azole antifungal. It was one of the first azoles, but it also in high doses can inhibit androgen synthesis, which can lead to adrenal insufficiency and decreased testosterone. So any patients who are on ketoconazole may experience these side effects. Some more targeted cancer drugs, imatinib, which is Gleevec. It's designed to bind with specific molecules with the goal of suppressing tumor growth, specifically if they're positive for the BCR-ABL tyrosine kinase gene of the Philadelphia chromosome. You can read that part there. Other tyrosine kinase inhibitors include cetuximab, Neb, trafitinib, panitumumab. Again, just kind of familiarize yourself with these agents. Nothing too specific, just being able to recognize them. The BCR-ABL tyrosine kinase inhibitors are the preferred medications for chronic myeloid leukemia, which we just discussed imatinib. It's highly effective and well tolerated. So other agents have come out and This is kind of where pharma is, has been heading, trying to produce targeted therapies that are effective and tolerated and not destroy normal cells. Here's some more examples of tyrosine kinase inhibitors. Here are examples of mTOR kinase inhibitors. There's temsirolimus and everolimus. And you can see there. You may have also seen everolimus and other things, including drug-eluting stents. Goes by the brand name of Xience. But if you hear about drug-eluting stents for patients, cardiac patients, the drug that is eluted is everolimus. Some more examples. Can look at this slide. Here's an example of CD20 directed antibody medications, rituximab. And you can see these are all MABs, so these are all monoclonal antibodies in the by classification. Okay, some more classes of medication, angiogenesis inhibitors. There are certain cancers that can cause angiogenesis, which is a proliferation of blood vessels. And the issue with this is that the blood vessels, they're not fully formed, so they're not very good in carrying out blood flow. So you can kind of imagine a freeway. Instead of building just a 2-lane highway, in angiogenesis it starts to produce like a 10 lane highway, none of which of the roads ever really make it to the goal or site. And so we just have this proliferation of blood vessels. And so what we would use are angiogenesis inhibitors, which suppress the formation of these blood vessels. And then they also help to deprive the tumors of their blood supply, which then leads to cell death. So the agent here is bevacizumab. There's obviously other ones, but this is the most common one. And it can be used as an intravitreal injection, which is straight into the eyeball, for those who suffer from wet macular degeneration. So bevacizumab in cancer, typically used in metastatic colorectal cancer. It can delay tumor progression for long life as you starve the bulk of the tumor from blood flow. This slide is about proteasome inhibitors, bortezomib, Velcade, which is used in multiple myeloma and lymphomas. This one, carfilzomib, can cause myocardial infarction. Here's some examples of histone deacetylase inhibitors, vorinostat and romidepsin. Here's ipilimumab, Yervoy, which is used for unresectable or metastatic melanoma. Here's some examples of biologic response modifiers. Corticosteroids, we won't spend too much time on, but we use it as a combination therapy. You should be familiar with its side effects, including the acute and chronic phases. They are helpful though, especially dexamethasone in preventing nausea and vomiting, reducing cerebral edema, reduction of pain, and it can improve appetite and promote weight gain, one of its side effects. Thalidomide was well known back in the day for causing severe birth defects, typically or namely phocomelia. These are its indications on here. More examples of other non-cytotoxic anti-cancer drugs. All right. And that's that for chemotherapy. So a lot of drugs I know. Uh, again, just kind of familiarize yourself with them, um, because it's a slew of medications. It's hard to keep up on. What we'll try to focus on in this lecture are the drugs for cancer pain. So just kind of read through these slides, but they talk about barriers to effective pain management. And unfortunately, um, we don't treat pain very well in America because of the fear for addiction and overprescribing and getting sued. So a lot of providers, yourselves included, will be reluctant to treat pain. Um, and we kind of stigmatize proper pain management in America by going after those who, prescribe opioids. And we may introduce a lot of regulatory barriers to proper prescribing. And so who suffers? The patients do, unfortunately. Just kind of read through that. Read through that. Uh, when you guys do practice, you should be familiar with those laws, because there's a slew of them, not just federally, but obviously in California. Okay, so when dealing with pain management and cancer, we should be understanding of the pathophysiology of the pain, and then understand the management strategy and how we would assess that patient's pain and come up with a plan. And then familiarize yourselves with obviously the pharmacotherapy of it, and provide the patient education. If you are going to work in a hospital setting, the Joint Commission uh, has a whole section on pain management and looks for proper pain management in its survey of hospitals. Pain is obviously a subjective assessment. Everyone is different. And for those who aren't lying, we're to believe their pain, however they prescribe it, and not be judgmental about how we would perceive that pain to be. There's typically two types of pain that we could deal with, right? So there's nociceptive pain, which is what we typically recognize pain as. The most familiar one would be somatic pain. That's just kind of like you punched a wall and hurt your hand, or got hit by a truck. You would feel that, typically described as aching. Sorry, not sharp pain, cramping. Contrast that with visceral pain, which is organ pain. And that's when patients will kind of describe that as more of a aching, deep, squeezing pressure. And so our medications are typically good for those, especially the opioids. They do very well in treating nociceptive pain. When it comes to neuropathic pain, it's not treated as well, but we do have those agents that can help to target neuropathic pain. All right, so how does pain originate in cancer? Obviously, as the tumor grows, it surrounds tissues and it starts to press on nerve endings, muscles, and organs. And then that causes pain receptors to fire, leading to pain. And it can be very, very, very painful. Cancer pain is one of the worst types of pain a human being can endure. And then just giving chemotherapy itself can cause pain, as we destroy the oral mucosa, as we destroy nerve endings and other types of cells, or the bone. This can all lead to, pain. Um, so we have to just kind of look through this slide here, more management strategy. This slide goes over assessment and evaluation, um, getting a good pain review and understanding that patient's pain is really useful in targeting treatment. Kind of go over that, go over that. Understanding the barriers to your assessment is also important. Okay, so that really is incumbent on establishing a good patient provider relationship. So just kind of make sure that you have that with your patient so that you treat their pain well. All right, pharmacotherapy. We're very familiar with non-opioid analgesics such as NSAIDs and acetaminophen. We should be familiar with opioid analgesics. We've touched upon these before. And then adjuvant analgesics can be used to treat either side effects of opioids and or neuropathic pain that the opioids don't seem to touch very well. We still follow the WHO ladder, which is the World Health Organization analgesic ladder, by starting off with a weaker agent. As if the pain is uncontrolled, we step up to a more a stronger agent. And then the last being high doses of opioids. Kind of review this slide. NSAIDs, just kind of review this slide. Just remember NSAIDs for their gastric ulceration, right? As we inhibit prostaglandins, we fail to create that protective lining of the stomach, and that can lead to gastric ulcerations. NSAIDs can also lead to acute renal failure. And then obviously they can cause bleeding. Can review that. Acetaminophen, we should be familiar with. So just kind of review this slide. Just remember, acetaminophen can be toxic to the liver, especially in high doses. So just be careful of that. Slide on opioids, you can review that. Can review this. These other agents are to be used with caution. We don't see this often anymore. Methadone is a very tricky medication, very effective, but it has a varying degree of kinetics that make its management pretty tricky. And if you don't know what you're doing, you can totally kill somebody with methadone. So we typically avoid that or leave that to expert pain management specialists. Codeine is not very effective for pain management. I think I've touched upon this on prior lectures, but codeine can be metabolized into morphine metabolites, thereby providing that opioid pain relief. But it's not as much as pure morphine, and it can be deadly in some patients, especially the pediatric population. Apiridine is an effective agent, but it is renally cleared. And so in patients who have renal toxicity or renal or have chronic kidney disease, for instance, giving apiridine can cause accumulation. And if you accumulate an opioid, you would have all the side effects you would typically expect of an opioid, including CNS depression, respiratory depression. But apiridine can also lower the seizure threshold, and so too much apiridine can induce a seizure. Opioids come in various routes. You can just kind of review that here. Managing breakthrough pain. When you get to this point, the preferred treatment regimen for patients with cancer is to provide a long-acting opioid therapy to reduce the overall day of pain, but then there's going to be episodes of breakthrough, and typically we would serve that by giving them a immediate um, acting opioid. So typically a common regimen you'd see is a morphine ER that kind of lasts all day, and then you would give them morphine IR tablets anytime they would have breakthrough pain. And so some of the characteristics we look for when providing acute pain treatment is obviously an opioid that has a rapid onset and short duration. So like immediate release oral morphine. Um, and then there are also quicker acting fentanyl formulations that are transmucosal, meaning that these are like lollipops or buccal tablets. And then also a fentanyl nasal spray. Side effects, you should review these. So for respiratory depression or an overdose, we would do naloxone, which is a pure opioid antagonist, right? So it sits on the receptors and blocks the opioids from interacting with those mu receptors. I've talked about opioids causing constipation, specifically a reduction in gastric motility. And so the only way to really treat this effectively is to give stimulant laxatives, right? Like Senna or bisacodyl. Oftentimes you'll see providers write for opioids with stool softeners like Docusate. And that's just a common, very, very common malpractice. Stool softeners don't do anything for the opioid-induced constipation. But you see it all the time. So just be aware of that. If you're going to have a patient on opioids and they're suffering from constipation, you should definitely prescribe them a stimulant laxative. For those patients who are on chronic opioid therapy but are falling asleep because of the CNS depression, some of those patients may receive amphetamines, which we've talked about in different or in a prior lecture, but you can see them on dextroamphetamine or amphetamine salts. Typically, we don't see that because, again, we are cautious about prescribing too many controlled substances. As you kind of open yourself up to liability and regulatory scrutiny. So in those patients, caffeine might be probably a more preferred agent to use. But then there's also modafinil and armodafinil that we've discussed in prior lecture. Agents for nausea, vomiting, very similar to what we would provide for patients who are undergoing chemotherapy, but serotonin antagonists are pretty effective in this regard. So ondansetron. If patients who are on chronic opioid therapy complain of itching, we would give antihistamines. Some of those agents can be anticholinergic, and so you could see urinary retention, orthostatic hypotension from that. This next few slides are adjuvant analgesics. They're not super effective in pain management, but they can be effective in enhancing analgesia along with opioids and or treating some of the side effects caused by opioids. So tricyclic antidepressants are very good in treating neuropathic pain, not so much in the somatic pain or nociceptive pain. So some of the agents there are listed. We can use old anti-seizure medications such as carbamazepine or gabapentin to treat neuropathic pain, and gabapentin is probably the most commonly prescribed for that instance. And then if we need an agent to just kind of numb out, cause anesthesia, lidocaine comes in various forms and is useful for that regard. All right, we talked about CNS stimulants. As far as antihistamines go, hydroxyzine can be used for itching for opioids, but you can sometimes see it prescribed with opioids and co-administered because hydroxyzine, specifically this form right here, hydroxyzine that comes from Vistarel, can help to potentiate pain relief. So the hydroxyzine of Vistarel is different from the hydroxyzine of Atarax in its salt form. So you can just kind of look that up. But Atarax is hydroxyzine hydrochloride. It doesn't potentiate pain relief like it does with the hydroxyzine of the visceral formulation. We've talked about steroids, and then bisphosphonates, again, great for anyone who's suffering from metastatic bone pain. These are some of the non-pharmacotherapeutic procedures that can be used. There's also a lot of physical interventions. So just kind of review that. And then psychosocial interventions. Some special populations to be wary of. Those who are suffering from undertreatment of pain. Elderly patients, we should be cautious about drug prescribing in the elderly patient. But we have to be careful because as we are cautious, we tend to underprescribe, and that may lead to undertreatment of pain in an elderly patient. So just kind of be sensitive to that. And obviously, those patients, especially elderly patients, will be more susceptible to side effects of these medications. Young children, kind of the same thing, right? So they can be more susceptible to the side effects of medications. So we got to be very cautious about that. And then opioid abusers, that's a special population. You kind of just have to key in on the behavioral aspects of the patient to kind of identify if they're abusers. But really pulling up a cures report is helpful to see the fill history of the patient. And as prescribers, you are required to pull up cures report anytime you prescribe opioids. So that is the law. Don't just rely on pharmacists to catch that for you. You have to document that you've reviewed that report prior to prescribing any opioid any opioid or controlled substance. Just slides just here for completeness. And I've talked about Joint Commission as mandatory. Okay, that was kind of quick. When I get to the quiz, I expect to focus mostly on pain management side, and maybe just touch upon some of the super common side effects or pieces of information with chemotherapy. I don't expect to dive into chemotherapy because it's so specialized. But again, I'll send out a review prior to the quiz being posted. And if there's any questions, feel free to reach out to me. Thanks for your time.